Good afternoon, and thank you everyone for attending today's webinar, Incorporating End-of-Life Care into Your Practice, presented by Alex Binder of VNA Health Group. Please be aware that there will be a question and answer portion today at the end of the webinar. To avoid frequent interruptions during the webinar, please type your questions in the question box located to the right of your screen. They will be answered in the order received during the question and answer portion. Additionally, an electronic version of this presentation will be emailed to all participants following completion of today's webinar, and a recorded version will be available on the website for members only. Again, we would like to thank you for attending, and I will now turn things over to Alex.
Hi, good afternoon, everyone, and thank you for coming to today's webinar, End-of-Life Care for Medical Practices. So I just wanted to start by giving you a short background of my role here at the VNA Health Group. We're in New Jersey. The VNA is a large organization that has hospice, they have home health, they have private duty, they provide therapy, and they also have what we call an Advanced Care Institute. In the Advanced Care Institute, there are two practices. One is visiting physician services. We have about 40 providers that make house calls. Palliative medicine is incorporated into that practice. These are essentially homebound patients, so we're taking care of them in end-of-life situations. And then we also have a separate practice that focuses on palliative medicine for non-VPS, non-visiting physician service patients, where another physician, typically in a hospital, will call in one of our palliative physicians to provide a consult. So those are the two medical practices that I manage, and again, it's under the umbrella of the VNA Health Group. So what we're going to talk about today, there's going to be a lot of background before we get into some of the meat, but we're going to talk about some demographics and aging population, the way people die, the expenses associated with death, the reality of the death. And then we're going to transition a little bit more into what we do in our practice, what other practices can do, what is palliative care, what is hospice, when would you attempt to provide these services yourself, when would you use another third party to help you with it. There are some forms and formalities, there's some regulation and guidelines, and then if we have time and if anybody is interested, aid in dying is here in New Jersey. It will become law on August 1st. So a lot of my talk and some of my slides are focused for the New Jersey market, but I am aware that there are participants on this call from a lot of different states. So we may not need to go into the aid in dying. So just a background on demographics, and I'm sure most of you are all aware of this, that, over the next 20, 30 years, the elderly population is going to expand considerably. And in 30 years, the number of people who are over age 65 will almost double. And, that means all the people that are on Medicare, it's going to create some type of challenges with providers, with payment schemes, with capacity, and so on. And even more daunting is if you look at the real elderly population, those that are over the age of 80. And by the way, if some of you do the math, you will be included in this 2050 group, being over 80 at that period of time. But that will close to triple. So again, the number of 80-year-olds will be close to triple the amount in just 30 years. So those are two pretty staggering demographic statistics. And, society is going to have to adjust to this, whether there's going to be lanes on the highways for different types of vehicles. But, candidly, we are going to have to account for these changes and this shift. And there are going to be new markets and new opportunities and new challenges to deal with a large propensity of elderly population. The other thing that's interesting is if we look back over the last 20 or 30 years, which isn't a long period of time, that the trajectory of death has changed. And what we mean by this is that typically there was a cliff event. If somebody was diagnosed with cancer, it would go relatively quickly. But now there are new medications, there are new treatments. Typically, we used to hear, oh, he had a massive heart attack. These are cliff events. And now with medicine, with technology, we're starting to see that the trajectory of death is changing, and people hover close to death, but for a more prolonged period of time. And what happens during that period of time, there's going to be peaks and valleys. There's going to be exacerbations. There's going to be hospitalizations. There's going to be need for different type of services and treatments. But, ultimately what we're seeing is people are living longer and they're living sicker longer. So how are we going to address that as a medical community? So here's the audience participation portion. I like to ask, have you ever considered how you would want to die? And I know that's a crazy question, but a lot of this presentation today is about death and dying. But when we ask this question, how do you want to die? And people have a minute to think about it. They usually respond, I'd like to die peacefully at home in my bed with my family around me and where I've made preparations. And this is not surprising or shocking to anybody, but it's going to be a sad event, but it's going to be as comfortable as possible. And, we need to keep in mind that this isn't the way typically people die. 70% of people who die in the United States die in a hospital or die in a nursing home. So understanding that 100% of us will die, that planning really plays a key role into what happens in those last 6 months, those last years of life. And that planning needs to be in place to avert the potential of this type of ending. If this is not what you want, if this is not what your patients want, then you need to make plans in advance to avoid this situation when possible. So we're going to talk a little bit about the cost of healthcare and the cost of dying. And, I like to show these slides a lot, is that when you look at the United States, and many of us know this, the per capita cost for healthcare in the United States, this is 2017 data, relatively recent, shows that on average, we spend $10,000 per person per year in the United States. And when we compare this to other developed nations, in some cases we're 2 or 3 times greater. And people sometimes say, well, you get what you pay for. We have a superior healthcare system. And there's a number of different ways for people to measure the efficacy of your healthcare system. One of them is infant mortality. Another has to do with diseases, and another has to do with life expectancy. And when you attempt to plot the cost versus life expectancy by country, you're going to see that the United States here has a very high cost, and this data only goes out to 2014, but we don't have such a superior life expectancy. So the quality is not phenomenal, and the cost is astronomical. And really a big piece of what we have to do in healthcare, and this is why the government and the payers and everybody are so anxious in changing payment models and having new entrants and new participants involved in healthcare, virtual visits. All of this activity is trying to get at this specific slide to figure out how can we improve quality and also lessen the cost. So the next few slides show us if we were to segment all of the population and to understand what type of impact each segment of the population has on healthcare spending, we see that healthy people represent 67% of the market, and they only represent about 5% of healthcare spending. These are average healthy people that are fortunate. They cost the system $500 a year, and that represents very little of healthcare spending. There's a group that have chronic illnesses, but they're well managed to some extent. So they may have diabetes, they may have heart failure, they may have other types of chronic conditions, but they're familiar with the medications, they're familiar with the treatment protocol, and ultimately they cost about 30% of the market share, but it's not astronomical. Something that really does cost us a lot is catastrophic care. And this is, when there's been a terrible tragedy, a car accident, something that's pretty urgent and requires very much heroic care, and that's highly costly. But we probably do a good job, and we probably wouldn't want this to go away, that if we're in a car accident or something terrible were to happen, that there would be urgent care that can help us and even correct our situation. So what's missing, this last piece of the pie, is the frail. And this is the frail, elderly, low mobility, typically multiple chronic conditions that many people experience in end of life. This is probably the last 2 years of life. If a patient or a family member doesn't experience a catastrophic event, the aging process will cause us to become frail. And ultimately, this portion of the population, these 7%, incur about 50% of all expenses. And however you slice the data, Medicare looks at the top 10% that incurs about 50% of the cost. The top 20% sometimes incurs up to 80% of the cost. So however you magnify or focus on the frail, debilitated, elderly, low mobility population, that's where there's tremendous expense, and there probably is significant potential to reduce those expenses. So shifting gears a little bit, and I'm going to speak a little bit more specifically about New Jersey, but many of you may be aware of the Dartmouth Atlas study, and you can look it up and understand how your state performed. But they basically looked at end-of-life care, end-of-life costs, end-of-life outcomes, and just compared state by state by state and said what is different in one state versus another, what is causing better outcomes, poor outcomes, and so on. So there's a few slides here on end of life. And in the last 2 years of life, the average expense in New Jersey is about $60,000. So that's about $30,000 a year in each of their last 2 years of life. And when you compare that to someone like North Dakota, it's double what happens in North Dakota. So, this #1 ranking that New Jersey has earned, it's really not the preferred placement where we would want to be. Another statistic is days spent in the hospital. And I don't know how many of you are familiar with if you're in a demonstration program such as CPC Plus, or if you've seen some of the recent information on primary care first, but Medicare is highly focused on hospitalizations. They're almost even looking away from total cost of care, and they're not so concerned about total cost of care. They know that the majority of cost is incurred in the hospital, and they're saying, how can we minimize hospitalizations? Because that will ultimately provide cost savings to the system. So, you see the statistics here, but again, this is a tremendous focus for Medicare 2020 and going forward. Days spent in the ICU is pretty significant in the last few years of life, and I'm going to ask everyone to think about how many physician visits do you think the average patient in New Jersey has in the last 6 months of life? Now, understand if they went into the hospital, there may be multiple physician visits during that hospitalization. So the last 6 months of life, how many physician visits does the typical New Jersey resident experience? Is it 10? Is it 20? Is it 42? The average patient in New Jersey has about 42 physician visits in the last 6 months of life. And obviously the patient ends up dying, so maybe it could be argued that some of those were not beneficial or productive or necessary, especially when you compare it to another state that, again, is less than half. And the last statistic is also astounding, is that close to 40% of the patients see 10 or more physicians during end of life. So we're getting a lot of utilization, we're getting a lot of activity, we're getting a lot of medical attention, but it's not necessarily changing the outcome. And the Dartmouth study ended up with, some pretty strong conclusions, and they said, we see this variation from state to state, but it's not as if patients are sicker in one state versus another. And this concept of additional utilization does not result in better outcomes. As a matter of fact, there's almost an adverse relationship that more activity, such as here in New Jersey, doesn't produce better outcomes, and it just produces higher costs. So again, all this focuses on the background of the cost of this end-of-life care and maybe what we can do to try to make an impact on that. So, some of the reasons for this is we like to say that the system is not perfect, that there aren't really any guidelines. When should we send somebody to the emergency department? When should a patient or family call 911? At the ED, when should they admit? They've created this observation unit, and they do that now, but do we admit? Do we just admit them overnight? Do we keep them for a week? All of these decisions, there's no real, this is always on a case-by-case basis. Another big one is, when do you schedule a follow-up visit? Is that in 2 weeks? Is that in 2 months? Is that in 2 years? Depending on who the physician is and what their protocol is, different patients are going to get different types of follow-up schedules. When do you see a specialist versus when do you see your primary care doc? When do you refer to home care? When do you refer to hospice? So this one little note about PCF is primary care first, and I'm just going to talk about that briefly, but in 2020, Medicare is going to introduce a new primary care demonstration program that practices can sign up for. And one of the biggest things they're going to do is reduce the fee-for-service compensation. There's going to be other ways to generate revenue. They're going to pay differently, but they're really going to reduce and flatten and minimize the incentive for additional visits. So they're going to say, basically what they're saying is, if you need a visit, then you better schedule that, and you'll get paid something, but you're probably not going to generate profit out of that visit. So if you don't need to schedule that visit, and you can handle that via a phone call, you can handle that via a text message or a video chat, then maybe that's going to be more valuable to your practice. So there are changes afoot, and these guidelines, sort of a lot of the activity that we see here is activity incented, and we're trying, payers are trying to move away from that. So that's, we moved relatively quickly. That's really the first major half of the presentation. We talked about demographics and how people are living sicker longer. We talked about this end-of-life expense and how that's a focus of Medicare. And, that it can be somewhat ineffective and inefficient in end-of-life. So what is it that we can do? What are some of the processes and programs that we can look at? So for those who remember, if you go back 10 years, there was the whole politicized death panels. And, death panels got a bad name and a bad rap. And, there's probably some value to a end-of-life conversation, especially if we don't call it a death panel. We're going to talk about palliative care. And I know that I've given this talk a couple times before, and I was surprised to realize that a lot of people had attended my presentation because they wanted to learn how to incorporate palliative care into their practice, because there's so much news and hype about palliative care, and there's a perception that, hey, this is another source of revenue. And I'm here to tell you that it's not really a source of revenue, but I'll explain more of that. We'll talk about hospice, we'll talk about end-of-life conversation, advanced directives, and advanced care plans. Again, going back, the death panel was a terrible label for end-of-life discussions, but this is the reality, is that this is just a photo from our practice, from our founder, Dr. John Salisbury, with one of our patients, and her daughter. This has become necessary, and this is something that doesn't really happen as frequently as it should. And of course, everybody's pressed for time. These are difficult and uncomfortable conversations. Palliative medicine has grown because physicians don't have time, or some cases the skills, to have these conversations. But that's what we're going to talk about a little bit more. So palliative care is really planning for this end of life. It's really for a patient who has some type of life-limiting situation, and it's to provide some type of holistic care: physical, emotional, medical, spiritual, everything that we can do to help that patient adjust and progress through their end-of-life situation. There's a concept that we want to improve the quality end-of-life care. In many cases, when patients are put on palliative care or hospice, their condition improves, okay? They're getting some type of additional attention, and that's beneficial. In some cases, they're taking them off of medications, and that has proved to be beneficial. So palliative helps to improve the quality of life, not necessarily the quantity. The one major difference between hospice and palliative is somebody receiving palliative care can receive curative treatment. If you want to continue to receive chemo, if you want to continue to have a procedure done, then that's absolutely available to you. In hospice, those things are scaled back and pursuit of cure is minimized. So in palliative care, usually there's one of two modalities, if you will. One is a consult and one is a comprehensive. So consult is something where we provide, we have a physician at a hospital. And if somebody in that hospital, if one of the primary care providers or an ED doc or an ICU doc or an oncologist says, you know what, this patient is facing an end-of-life situation, and we would like to call in a palliative consult. That palliative physician would go out, assess the patient, assess the charts, have a discussion with the family, and basically make them aware of their options. You can have a third round of chemo, you could go on dialysis, you can get a feeding tube. What we typically see, what you can typically expect, and so on, and they'll have this conversation. It may be one visit, it may be two visits, it may require a follow-up conversation with the oncologist, with the primary care provider, with the son in Texas. So all of that occurs. If you think about that, you know, in a hospital, I imagine the reimbursement for that first visit is, I'm going to guess, $150, and maybe that secondary visit is $100. This is not a highly productive environment. These are difficult conversations. Sometimes they're long conversations. As I mentioned, sometimes there's follow-up conversations. This practice that I manage, the palliative practice, we are in 6 different hospitals. It is not a profitable practice. I will share that with you. It's not a profitable practice. And we provide just consults. So we are probably as stealth as we can be to get in there, to do what we need to do, to coordinate what we need to coordinate, and to get out. There are other programs that provide more comprehensive palliative care. I know some hospice agencies and home care agencies have a division that provides palliative, and it's much more comprehensive. They may have a nurse that's involved on those cases, as well as a physician. They may have a social worker involved who helps people adjust to some processing of the end-of-life situation. There may be clergy on that staff, that interdisciplinary team that they bring together. I will tell you, there's not a real good payment model for this type of service. If it's not hospice, okay, it's essentially back into a fee-for-service world. And fee-for-service, with all of these adjunct resources that you bring to the table, becomes extremely costly. So, you know, the point here is both of these present financial dilemmas. So we have a saying here that there's a place in heaven that for people who perform this type of work. There's just not a reimbursement model yet, okay? We think we're getting there. We think there's going to be some type of incorporation of value-based payments for people who can provide this end-of-life value. But right now, palliative is a great concept, and it's talked about a lot, and it's really, really valuable to the patient and the family, but it's not necessarily recognized or rewarded by the payers. So hospice, in terms of what's different, you know, hospice is for patients with a terminal illness. You need to have a prognosis of 6 months or less. It's much more flexible with palliative. There isn't a specific time frame on the prognosis, but the patients have determined that they're not going to seek curative care. Typically, they're going to decide that they're not going to go back to the hospital, that they can receive hospice at home. And there is a complete multidisciplinary team. There are volunteers. There are music therapists in some cases. There are animals that come out, therapy dogs, and so on, as well as nurses, social workers, caseworkers, medical directors, and so on. The one difference is hospice has a very strong, from my perspective, financial payment structure. Hospice pays in the neighborhood of $250 per patient per day. So you don't necessarily see a patient every day on hospice. You don't necessarily send a home health aide or a nurse out there every day. But at the end of the month, there's a $4,000 payment. And if you can allocate your resources, keep that patient comfortable, keep that family satisfied, then there is profit in a hospice model. So, as I mentioned, palliative is still predominantly fee-for-service. There are risk-based contracts available. So the palliative groups that are somewhat successful have negotiated with a payer and said, look, we will focus on these very sick patients that are high utilizers, and we will attempt to bend this cost curve, and we will, then contract with you where we'll share these savings. In the hospital, it's very valuable, and a lot of healthcare and hospital systems have bought into this, and they are having palliative services in the hospital because maybe the emergency room or in the ICU, those physicians need to concentrate on what their specialty is and what their focus is, and that they can transition these patients to a palliative doc that can have this conversation. It's very valuable to the families and patients. If it could be provided to everybody during end of life, that would be fantastic. The question is, can a PCP provide this service? Within our other practice, the visiting physician services practice, where we go out to the home, we provide this palliative. It's ingrained in what we do. It's part of our philosophy. I'll talk a little bit more about that, but it's not that radically different from why and how physicians learned in medical school. All right, they just need to get a little bit additional training, and it's a lot about having this emotional conversation with patients. So whether a PCP or an oncologist could do that, it's definitely a high likelihood. But one of the challenges, agendas need to be aligned, and there's slow progress with that. An example is, another treatment will generate revenue for some physicians, whether that's a surgeon or an oncologist or whoever. If we do another round, we'll get another set of payments. And I know this is a terrible perspective, and I hope this is the minority, but if that is a motivating factor, then palliative care is going to reduce that opportunity for revenue. So what can we do as citizens, as individuals, and as practice managers? So there are a number of things, and really they fall into these two big categories. One is advanced directives, and another is called advanced care planning. So an advanced directive, if you think of it this way, the three things listed under the advanced directive are usually what is covered under an advanced care plan. So the advanced care plan is really an umbrella, and it's a billable event. So we'll get back to that in a minute, but what do you cover during an advanced care plan? There are typically specifically documents: healthcare power of attorney, a living will, and a pulse. So under the advanced directive, again, there are typically these three documents. A healthcare power of attorney is really what they call a proxy directive, right? This is where you assign somebody to be your proxy in the case where you cannot communicate what your wishes are. So you will write down if in fact I am paralyzed, if I am in a vegetative state, if I am XYZ, I would like this to happen. I would not like this to happen. I'm sorry, I'm getting ahead of myself. This is where the healthcare power of attorney, the healthcare proxy, is where you say, if I cannot voice my decisions, I will direct Mary Jo, my daughter, my wife, to make those decisions for me. So I apologize, I was ahead of myself there. The power of attorney is where you simply are appointing someone else the power to make these end-of-life decisions for you, a surrogate. The living will is really where you give your direction. So the living will is your instructions. Again, if I was in a vegetative state, what would I prefer to happen? Would I want to get a feeding tube? Would I like CPR started? Would I want to have mechanical ventilation? Those types of things. So the living will is in place, and it will cover whatever you dictate in there. Now, in a case where you have a living will and you also have a healthcare power of attorney, the healthcare power of attorney would only step in where it's not defined in your living will. So if there's a scenario that hasn't been anticipated, then your healthcare proxy can make that decision. So these two documents are very valuable. And where we are moving to now nationally is towards a PULSE document. A PULSE is really a type of living will, but it's much more recognized within the medical community. It's considered physician's orders. It covers a lot of what is in the living will, but it does it very succinctly. It's on one page. So sometimes people break out a living will and they have to start to rifle through the pages to determine whether we should put in a feeding tube or not. It's very specific, and it is becoming much more common and recognized and respected by the medical community. Typically what we see is that patients are going to have this advanced directive, they're going to have this living will, they'll update it periodically, but as their condition somewhat worsens, they become sicker with an advanced illness, then they move towards a PULSE document. So that's really the progression of what we see. So the advanced care plan is about a conversation. And what we talk about in that conversation, in both our palliative practice and the visiting physician practice, there's really 4 or 5 steps. The first is to ask this patient and the family, do you really understand your illness? What do you know about it? And we all know that, by the way, that physicians or providers interrupt patients within 17 seconds, okay? It's typically we don't give patients more than 17 seconds to tell us their side of the story. So in this case, we want to understand, what do you know? What were you told? What are your expectations? And then sometimes we ask for permission. Would you like me to explain what the way CHF works? Would you like me to share with you what we typically see in a COPD patient? Okay, so now you understand that. You understand where your father is at. You understand where this is going. You know, so based on that, what do you envision? What do you anticipate? Do you anticipate him going back to the hospital? Do you anticipate him having an event? Do you anticipate him wanting to stay home? You know, and then, you know, again, we talked about having this in the third person, which we would say we typically see that a patient with this disease would have this experience. And then we ultimately ask them again, in the end, based on everything we talked about, what is it that's really important? What are your wishes? What do you expect? What do you want me as a provider to be cognizant of? And if that is, I want to stay alive forever, or, you know, then we'll write that in the chart and we're going to provide whatever heroic methods we can. But if they say, I don't want to go back to the hospital, I want to stay home, I want to be comfortable, I want to be around my family, I want to have chocolate, I want to do whatever it is, then we'll go ahead, we'll write that in the chart, and we'll make sure that everybody is aware that this is what their wishes and goals are. So, you know, another question is if a patient knows that they're dying, should we let them know? We think if they're ready for this, this is valuable. I think a lot of people are shy away from telling patients their prognosis, their actual prognosis, and in many cases it's very, very difficult to prognosticate, but if a patient only has 3 or 6 months left, we think it's only fair that they know about that and they have the opportunity to plan for that, and maybe they're going to make sure that, you know, they have their family come and visit or whatever it is that they want to accomplish. So this advanced care plan, if you start at the bottom here, this is a billable event. There is the CPT code. This is essentially an end-of-life conversation. It usually does incorporate those advanced directives. We, in many cases, leave behind a pulse, and we'll capture that on the next visit. So we're not going to go through that in detail with them, but we're going to tell them this is important for them to preview after we've had this discussion that I just showed you on the previous slide. And after you go through all of that, you will then document in the chart. We actually have been audited by CMS because we do a lot of advanced care plans, and they figured something wasn't right about what we were doing. But you need to say, who did you talk to? What did you talk about? What was the result of that conversation? And how much time was spent? And as long as you say, I talked to the family and Mary Jones was there, we talked about the prognosis and end of life, they don't want to be put on a respirator, we left a pulse document behind. You don't have to get a completed pulse document at this point. And we spent 25 minutes. It doesn't have to be the entire 30 minutes. It needs to be the majority of 30 minutes. So that's really 16 minutes or more. And this can be provided by a physician or a nurse practitioner or a PA. You can do it at the time of an annual wellness visit. You can do it at the time of an E&M visit. And I think it pays around $85 or something like that. If it takes longer, there is another CPT code for the next 60 minutes. So we covered a lot. I know this says enjoy the rest of your conference, but I guess this isn't appropriate. But I thank you for your time, and if there are any questions, we can go over them now.
Okay, so we don't have any questions right now. If anyone has any questions for Alex, his information will be in the email that goes out with the presentation, and you can email him directly. And thank you everyone for attending, and have a great day.
Thanks everyone.